Is this sound on your side, Mike? Is this sound on your side, Mike?
Hello, welcome and thank you for joining us for our final webinar of 2023. I'm Amy Powell, Pheo Alliance Community Engagement Specialist. I'm here with Dr. Ali Alzahrani and a special guest. I will provide a proper introduction in a few minutes. This program is brought to you by Pheo Alliance, whose mission is to empower patients with pheochromocytoma or paraganglioma, their families and medical professionals through advocacy, education, and a global community of support, while helping to advance research that accelerates treatments and cures. Special thanks to Lantheus Progenics for making this webinar possible through an educational grant. I'd like to talk to you about some upcoming events. This evening at 3:30 p.m. Pacific, 6:30 p.m. Eastern, we invite you to join us for our holiday potluck and cookie contest. We'll have games which will feature, and the contest which will feature a pretty swell prize for best cookie. You can learn more and RSVP on our website. That's www.pheopara.org. Our next monthly peer support meeting will be Tuesday, January 9th at 4:30 Pacific, 7:30 Eastern. Links to register can be found on our website and social media channels. On a special note, through the end of the year, the Pheo Para Alliance is conducting its year-end fundraising drive. Your generous donation ensures that we can continue our mission of supporting those with Pheo Para, not only by providing up-to-date information on these tumors, but via important programs like outreach to the newly diagnosed, our monthly peer support meetings and one-on-one peer support program, healthcare provider education and outreach, our Centers of Excellence program, and our educational webinar series that brings you important events like today's webinar. Now more than ever, your help is needed to ensure that our work to support those with Pheo Para can continue. You can make your donation today by visiting us online at pheopara.org. The information presented in this webinar is for educational purposes only and should not substitute for the advice of your doctor and medical team because they have in-depth knowledge of your medical history and current situation. Today's agenda is going to be slightly different than our typical webinars. Our topic today, as you know, is the multiple phases of SDHB-related paraganglioma, and it's one of great interest to me personally. As many of you know, I lost my mother and brother to Pheo Para caused by an inherited SDHB mutation, which presented very differently in both of them. My brother John only had head and neck tumors, while my mother had tumors in her neck and her left adrenal gland. In addition, my brother's tumors were found much earlier and grew at a much faster rate than my mom's. So after I get done with our introductions, Dr. Alzahrani will speak for about 30 minutes. When he's done, he will introduce his special guest who will tell his story, and then we'll launch into your questions. Now it's my pleasure to introduce Dr. Alzahrani. Ali S. Alzahrani, MD, is a consultant endocrinologist at King Faisal Specialist Hospital and Research Center and a professor of medicine at Al Faisal University in Riyadh, Saudi Arabia. He was the recipient of the 2015 International Clinical Award from the American Association of Clinical Endocrinologists, Orlando, Florida, and the IBN SENA Distinction Award from the AACE Gulf Chapter in 2016. He is a member of the American Thyroid Association Research Committee and the International Thyroid Oncology Group. He was the editor-in-chief of the Annals of Saudi Medicine. He is an editorial board member of Thyroid, the Journal of Clinical Endocrinology and Metabolism, and Endocrine. He is also an academic editor of the PLOS. Professor Alzahrani has more than 200 peer-reviewed articles and has presented more than 150 lectures internationally and nationally. His academic interests and clinical molecular research in the areas of endocrine oncology and endocrine genetics. Dr. Alzahrani, it's my pleasure to welcome you and your guests today.
Thank you so much, Amy, for inviting me to participate in this exciting webinar and exciting program. I would like also to thank Dr. Carl Bakak from NIH and Stephanie for allowing me to speak to you. I'm especially excited today, although I'm a bit intimidated talking across the globe. But this should be an interesting talk and hopefully useful to our patients and colleagues. So let me share my screen. And let me know if you see my screen, my slides.
We can see it.
Excellent. So today we're going to talk about the many phases of SDHB related paragangliomas. I have nothing to disclose, but I have two disclaimers. One is that I am not a native English speaker, and I apologize if my accent in any way not well understood, but I'll do my best. And the second thing is, for a physician like me, it's always difficult to organize a lecture or presentation for non-medical people. Not that I am underestimating the intelligence of people, but we traditionally use terminology and technical language in medicine that may not be quite familiar for the public. But again, I will try to do my best to explain things in a language that is hopefully understandable to everyone. This is the agenda. I'm going to give a little introduction, and I know the audience are quite familiar with this disease. I thought really, although you may have heard this in the past, but I think it's always fascinating to know how we got to this level of understanding of any subject. The history is always inspiring. So I'm going to take you in a little bit of historical background, how we came to understand the pathology and pathogenesis of this disease. Then we'll focus on some interesting and important aspects, especially for patients and their family, of the SDHP-related paraganglioma, review briefly some of the work that we published, and present some of our patients, some of the challenging cases that illustrate some aspects, the many phases of SDHP-related paragangliomas. So I'm sure everybody knows that when we talk about pheochromocytoma, we are talking about intra-adrenal neuroendocrine tumor, or the intra-adrenal tumors, and then paragangliomas are extra-adrenal pheochromocytomas. Although those tumors are very related and more or less similar in many aspects, but there are differences actually in their behavior, in their tendency to metastasize, in their secretory products, and even in their response to therapy, that it's important for us as a physician to understand, and also for patients. Now, generally speaking, paragangliomas can happen anywhere in the body. Pheochromocytoma, as we just mentioned, is a tumor of the adrenal medulla, the inner layer of the adrenal glands. But paragangliomas can happen anywhere in the body because we have what's called autonomic nervous system with ganglia spread throughout the body, starting from the head, in the neck, in the chest area, abdomen, pelvis. However, there are 5 common places that we see paraganglioma in: the head and neck, what sometimes we call them carotid body tumors or glomus jugular, but at the end of the day, they are head and neck paragangliomas. Mediastinum, which is in the chest area, around 10% of paraganglioma occur in the mediastinum. The most common site is actually the abdominal paragangliomas, along this sympathetic chain. And then pheochromocytoma in the adrenal medulla. And as I mentioned, they can happen anywhere. We have seen patients with the urinary bladder paraganglioma. We have seen patients in the liver, in the lung, even in the spinal cord. So essentially, most of the places are prone for paraganglioma, but the most common sites are these 5 sites. Now, going into the history, this gentleman is a German physician who described the first case in the modern history in 1886. He wrote the first description of a patient with pheochromocytoma. And at that time, pheochromocytoma, the term pheochromocytoma did not exist, was not existing actually, and he did not use this. In fact, this is basically the article that he wrote, or the reference of the article that he wrote, and it was written in this German language journal, Archive of Pathology, Anatomy, Physiology, Clin Medicine, and it was in 1886. His description of the case was translated in another journal in 1985, so 100 years later, and this is actually his title. And if you look at the title, the word pheochromocytoma was not there. In fact, it was a descriptive term for what happened with this patient. So we call it a case of bilateral, completely latent adrenal tumors, and latent because they only discovered it at autopsy, with concurrent nephritis. Nephritis here refers to the damage in the kidney from the severe hypertension that this patient had, and changes in the circulatory system. This is basically the heart, the palpitation, the hypertension, the hyperdynamic circulation, and finally the damage to the retina, retinitis. So this is his description of the case, and he really wrote beautiful description that was interpreted from the German language to English in this article that was published in New England Journal of Medicine in 2007. And when you read it, it's really amazing. He gave a very precise description of how patients with pheochromocytoma paraganglioma usually present with. So just looking at this is an 18-year-old girl who came with 3 attacks of sudden onset palpitation, and anxiety, dizziness, headache, vomiting, constipation, and increasing weakness. I'm sure some of you may have experienced these symptoms. She was hospitalized in December 11, 1884 and died 10 days later. She died because at that time nobody knew what she had. When she presented, she was noted to be fairly malnourished, pale, with agitated heart action and strong pulse, epigastric pulsation, photophobia, Adriatic pupils, and her urinalysis revealed proteins, casts, and hematuria blood, which are signs of damage to the kidney because of the hypertension, uncontrolled hypertension. Retinoscopy, that's the eye examination, revealed papilledema, yellow-white infiltration, whitish stippling, multiple hemorrhages, and edema of the macula. And these are all features that we know as manifestations of severe uncontrolled hypertension. And during her stay, she developed paroxysmal tachycardia up to 180 beats per minute, sweating attacks, headache, vomiting, visual deterioration, arrhythmias, nosebleeds, and anxiety, and at the end, severe chest pain. So this is beautiful description of how typical attacks of pheochromocytoma paraganglioma happen. Now, this case was underwent autopsy examination, and this is the pathologist, Max Schutilis, again, a German pathologist, who described actually the case. In his description, he basically showed that tumors or the pheochromocytoma, this is not the sample of the patient, but a pheochromocytoma, when they are put in a solution called Miller solution, the tumor becomes dark. And this is where the name came from, because pheochromocytoma refers to basically dark color tumor or dark color cell tumor. And this reaction or this change in the color is referred to as chromatin reaction. And he is the pathologist who looked at Frankel's patients, the 1886 young woman who died from pheochromocytoma. Now, the term pheochromocytoma itself was only coined for the first time by a pathologist, a German pathologist by name of Ludwig Beck in 1912. So this is like 30 years later after this young woman died. And pheochromocytoma is derived from Greek. Phios means dark, chroma means color, chitos means cell, and oma means tumor. So you could say tumor of dark color cell, basically. And that's how pheochromocytoma looks like macroscopically, and even when we look at it with a special stain under the microscope. The first people who operated on the same year in 1926 on the first patients, or these are the first surgeons who successfully removed pheochromocytoma. One is César Roux from Switzerland, and the other one is Charles Horace Mayo, who is the son of Mayo, who established Mayo Clinic at that time. So these are the two surgeons who operated on patients with pheochromocytoma for the first time. Now, it's interesting that in 2007, Hartmut Newman and his colleagues tried to find the history of that young woman who died in 1886. So this is more than 130 years later. And they went back and they traced the family. This is the patient. This is the young woman who died from pheochromocytoma in 1886. And this is her big family pedigree. And you can see she has around 6 brothers. And some of them had children, and then grandchildren and grandchildren. So they were able to construct the family tree after a huge effort, actually, that they described in the article. And they were able to get sample from this gentleman who was affected by pheochromocytoma and medullary thyroid cancer. And what they found actually is that he had RET oncogene, which we know today, RET oncogene mutation, which we know today to be the cause of multiple endocrine neoplasia type 2, which include medullary thyroid carcinoma and pheochromocytoma. So again, you can see here the title of the article, Evidence of MEN2 in the Original Description of Classic Pheochromocytoma. So this is really interesting history. Now, moving beyond the history, as medical students, and I remember this, and it's still up till this time frequently taught in the medical schools, we have something called rule of cytoma. And the rule of 10 is something that we are taught to memorize so we can remember. It's an axiom that is taught to medical students and people in the medical field just to remember. So what is the rule of 10 in pheochromocytoma paraganglioma? 10% extra-adrenal, in other words, paraganglioma. 10% occur in children, 10% bilateral or multiple. 10% come back, recur, especially if it is extra-adrenal. 10% malignant. And 10% hereditary, but this 10% hereditary is no more correct. What we know today is that 40 to 50% of paraganglioma, pheochromocytoma are hereditary. So this is one violation of this long-standing rule that we have been taught in medical schools. And how did this happen before the year 2000? I'm sorry. Before the year 2000, there are only 3 genes that we know. Neurofibromatosis type 1 with the gene NF1, multiple endocrine neoplasia type 2A and type 2B, and the gene is RET. And then von Hippel-Lindau syndrome, and the gene is VHL. And you can see here, these are the only 3 genes, and this is 10% of the total patients with pheochromocytoma. But a major landmark study that was published in 2000 by this gentleman, Bora Basil, and his colleagues from University of Pittsburgh made the whole difference. This was significant enough to be published in a very famous journal, Science, and this was like breakthrough. Basically, hereditary paraganglioma were found to be due to mutations in SDHD, D, delta, not B yet. And that was the first time we recognized that this complex of gene, the succinate dehydrogenases, are the underlying genes for some cases of hereditary paraganglioma and pheochromocytoma. So what is SDH, succinate dehydrogenase? This is a picture of the mitochondria of the cell. This is a sketch of a cell. So the cell has mitochondria, has a nucleus, and has cytoplasm. So the mitochondria is the powerhouse of the cell. It is where the energy is basically generated. And this comes as a result of several chemical reactions. So SDH is an enzyme that helps changing this molecule succinate to fumarate. And this cycle is called Krebs cycle or tricarboxylic cycle. And these reactions finally lead to generation of a substance called ATP, which is an energy molecule. So if you have defect in the succinate dehydrogenase, the whole cycle is paralyzed basically, and succinate cannot be converted to fumarate. And that has consequences that result finally in tumor formation. So this is the succinate dehydrogenase, and the succinate dehydrogenase is not one protein. It is actually 4 subunits and even an accessory subunit. So we have succinate dehydrogenase A. This small molecule has 4 subunits: succinate dehydrogenase A, B, C, and D. Today we're talking about B, but mutations in any of those result in paraganglioma and pheochromocytoma. And you can see here that those subunits lead finally, they are a complex, enzyme complex that lead to succinate to change to fumarate inside the mitochondria here. So following Bora Basil's discovery, I'm sorry for this, multiple papers came. The next paper came is about succinate dehydrogenase C, this one. And that's in 2000. And then in 2001, succinate dehydrogenase B. And then in 2009, we have succinate dehydrogenase AF2, associated factor 2. And then finally, in 2010, we have succinate dehydrogenase A as a tumor suppressive gene causing paraganglioma. So the discovery that that all of these subunits can be mutated, changed, and lead to, again, a block in this reaction, the succinate to fumarate, was a major discovery, and all happened mostly in 2000, 2001. So talking about SDHP, since it is the subject of today's lecture, this is from the paper of Bora Basil and colleagues. Basically, they had 4 families, and you can see those families had paraganglioma of the head and neck. So for example, family 1 here, K1, this is grandmother, and this is her daughter, and this is her son. Squares are sons, and circles are basically or male, and circles are females. So all of them had paraganglioma, and it is because of mutation in this gene. The same thing here: mother and her son, 2 sisters, a woman and her nephew. So this is what happened in 2000, 2001. By 2012, this is from a review article, we have 12 genes. Beyond the SDHs, we have RET and F1, PHL that were known, but there are new genes: MAX, TMA, M127, EPAS1, FH. And you can see this sketch of the cell shows you where those genes are. So for example, the SDHs are inside the mitochondria. PHL is in the cytoplasm, MAX is in the nucleus, RET is on the cell surface, and NF in the cytoplasm, and so on and so forth. Now, in 2017, this is a publication that more or less completed the work on pheochromocytoma paraganglioma. This is part of the Cancer Genome Atlas, which is a project supported by the United States government to basically completely and comprehensively sequence and genotype different cancers. And one of them is paraganglioma and pheochromocytoma. So today we have around actually 30 genes. Even after this article, we continue to discover new genes. We have around 25 to 30 genes that are the causes of paraganglioma, pheochromocytoma. And you can see here several genes were discovered in the last 10 years. This is 2012. And then you can see there's a crowdness here in this slide or this diagram about the discovery of new genes, and the issue continues. Again, our subject is SDHP. So one of the questions that will come and we will discuss and is important for everybody: if I have SDHP mutation, what is my chance to have the disease? It is not automatic that if you have SDHP mutation that you will have the disease. This is called penetrance. So the penetrance of SDHP, fortunately, is very low. This is from several studies. So by the age 50, only 20% chance to develop paraganglioma. Even if you have mutation, you have only around 20% chance of developing paraganglioma. In another study, by 60 years, around 42% develop paraganglioma. In another study, 22%. In a third study, by the 80 years of age, only up to 65%. So overall, less than 50% of patients carrying SDHP mutation will develop the disease. So the penetrance, the manifestation of the disease, the development of paraganglioma pheochromocytoma in SDHP is relatively low, less than 50% in general. You can see SDHA is even lower. SDHC is quite low. SDHD, on the other hand, is not that low. It's around 40%. VHL is up to 20%. So this is good news about SDHP. But the less good news is this: if you develop the disease, you have up to 75% chance of having metastasis. So the disease starts somewhere and goes to another place or other places. So SDHP, unfortunately, is the highest risk in terms of metastasis, although the penetrance is less than 50%. But if you develop paraganglioma or fuchromocytoma because of SDHP, you have up to 75%, anywhere between 35 to 75% of developing metastasis. SDHA is also high risk, but the other ones are very low risk. SDHC, D, EBAS, and VHL are much lower. So the highest risk is actually with SDHP. Now, so the question is basically, since this is the case, what is the recommendation if I have a kid or if I am myself carrying SDHP or SDH mutation, whether it's B or A or C or D? This is the recommendation, the most recent recommendation from a group of experts who published actually consensus on this. So if the patient is an adult more than 18 years and he is carrying the mutation but does not have the disease yet, the recommendation is to have clinical examination, especially blood pressure measurement, to do biochemical testing, basically measuring catecholamines, and to do MRI from head to pelvis, because paraganglioma in this situation can be anywhere from head to pelvis. And maybe in an adult to consider PET scan, gallium-68 dotatate PET scan. So this is the initial screen. If you happen today to be discovered to have SDHP or A or D, this is what you need initially. Now, if you don't have a disease, if this testing reveals no disease, then you need every 12 months to have clinical examination. That's basically blood pressure, biochemical testing, measurement of plasma or urine metanephrine or catecholamines, and then every 2 to 3 years to have MRI from the head to pelvis. There is some controversy whether you need, again, gallium dotatate PET scan or not. We try to avoid it because it has radiation. So the MRI does not have radiation, so it seems to be a logical thing to do. But I would say, personally, it may not be a bad idea to get a gallium PET CT scan every 3 to 5 years, just to make sure that you're not missing something small somewhere. For children, the recommendations are similar, except we do clinical examination, we do biochemical testing, measure metanephrine, we do MRI because it has no radiation, but we don't subject children to gallium-68 PET CT scan because of the radiation. Now, when should a child who carries this mutation start to be examined? If he has SDHP, which has the highest risk for metastases, the recommendation is to be tested for the first time anywhere between 6 to 10 years. So we don't have to examine somebody or investigate a child who is 3 years carrying the mutation. We don't have to subject him to all of this because studies have found that the chance is extremely small to have a disease before 6 years. For other SDH, A, D, C, the risk is even lower. So the first time to be tested and have MRI and biochemical testing is recommended to be anywhere between 10 to 15 years. What do we do with the children? We also continue to follow them every year with a clinical examination. Notice the biochemical testing in adults every year. For children, the recommendation every 2 years. An MRI here is 2 years to 3 years. Here, again, is 2 years to 3 years. We don't use gallium PET, neither in the initial screening nor in the follow-up. Let me share with you in the next 5 minutes some work and also some studies that we have done so you can probably understand the spectrum of the disease in our part of the world. So this is a study that we published in 2019. We took 101 patients who did not have family history. Basically, what looks like sporadic disease, non-familial. And you can see the median age is around 38, ranging between 8 to 81. 61 were female, 40 were males. The tumor has different characteristics pathologically. Most important is that we had patients who had pheochromocytoma only, some of them bilateral, abdominal paraganglioma, some had paraganglioma in the head and neck. You can see 39 patients. I'm sorry. And then other sites. So what we found, out of 101 patients, 64 did not have mutation. Remember, those patients did not have family history of pheochromocytoma paraganglioma. They are referred to sometimes as apparently sporadic. In other words, they look like sporadic, but when they have genetic testing positive, they are not sporadic. They are hereditary. They are familial. We found that SDHP is the most common gene in our population. 21 out of 101 were SDHP positive. We saw some SDHC, 4 of them. RET was present in 1 patient, SDHD in 3 patients, and then VHL in 2 patients, and then MAX in 2 patients, SDHA in 1 patient, SDHA F2 in 1 patient, TMA 127 1 patient, and NF1 1 patient. I would say this pattern is probably similar to the West. I did not really see something unusual except the high rate of SDHP mutations. Because this is the most common mutation in our most common gene mutated in our population, we looked at patients who had this mutation. We found that this mutation is recurrent, very common. It's a mutation at codon 90, and it's called truncating mutation. It actually chops the gene out. So we wanted to study this more thoroughly, and you can see the title, one genotype, that's SDHP mutation R990X, but they have multiple phenotypes, which means the expression of the disease is variable. And I will show you that. So this is the 13 patients, mostly young patients. This is the age. We had 8 males and 5 females. Family history was present only in 4 patients. The rest did not have family history. You can see the tumors were mostly in the abdomen. We had 1 or 2 patients with the adrenal. We had 1 or 2 patients in the head and neck area. The size of tumor varies between 3 centimeter and 18 centimeter. Around 6 patients had distant metastases. They were treated mostly with surgery, S-axis surgery, and a good number of them achieved remission, but some of them had metastases. We treated them with different chemotherapy, tyrosine kinase, PRRT, lutetium. We lost actually 4 patients, and the other ones either were in remission or recurrence. Now, what is this one genotype, multiple phenotype? I'll just show you one good example of this. This is a woman, and this is her brother. So this lady had around 9 centimeter mid-abdominal tumor that was operated before, but came back, and she had also metastases. She received 1 cycle of chemotherapy, this classic cycle VCD or vincristine cyclophosphamide doxorubicin, and only after 1 cycle, the tumor disappeared completely. You can see this in the CT scan. This large mass is not anymore there. And you can see even on the PET scan, this uptake is essentially nil here, or only little. This is her brother. He came with this extensive metastasis. He received the same therapy, 6 cycles, not only 1 cycle. And he continued to progress, and unfortunately, he recently died. So the first phase, referring to the multiple phases, the first phase that I want to show you is, although SDHP is the same mutation in the family, but they can have different response to treatment, and they can have different expression of the disease. And this is a good example. Those 2 siblings were living in the same environment, the same house. They are carrying the same mutation, but the pattern of the disease, the response to treatment was completely different. And this is something that we don't fully understand, but it is a fact. This is another phase number 2, unusual location of SDHP-related paraganglioma. This is a patient who was referred to our ENT colleague as nasopharyngeal carcinoma because the paraganglioma was in the mid-head. You see, this is an MRI of the head, and you can see this is in the middle. Usually, paraganglioma is on the right or left, but this is in the middle. So he was thought to have nasopharyngeal carcinoma. He was referred to ENT, the ear, nose, throat specialist. They consulted us because he has severe hypertension, and he had CT scan just to make sure that he does not have metastases. And then the CT scan included the upper abdomen, so he had this big mass. So we realized the moment we saw him, this is very characteristic of pheochromocytoma, that this is pheochromocytoma or abdominal paraganglioma, and this is a head and neck paraganglioma. So it is not nasopharyngeal carcinoma, it is actually multiple paraganglioma, and in fact he has SDHP mutation. This is the normal sequence, and you can see he has mutation here low. And this is the same mutation that I showed you. It's very common in our population. It's probably a founder mutation in our population, R90X. This is another patient, and the face here or the message here is a new manifestation of SDHP. Although we are not absolutely sure, but this is a patient who presented with primary hyperparathyroidism, sorry for this, and thyroid cancer. He has SDHP mutation. He had multiple paraganglioma, but 2 features that are not recognized before to be part of SDHP were present in this patient. So this is his paraganglioma in the abdomen. He underwent resection of this, and he was okay for 3 years, but he presented with tinnitus. And then he had this mass that is clear on the PET scan. So he had another paraganglioma in his head. He underwent another surgery for the head and neck. And he presented with high calcium. And this is the reason for this is he has elevated level of parathyroid hormone, something that was not reported before. And this is why we call it a potentially novel manifestation. And he has mutation in the SDHP, as you can see here. This is the normal sequence. When you see 2 spikes, this is a mutation. And when we went and screened his family, he has a sister who is affected. His daughter, who is now 4 years of age, is also carrying the gene, the mutation. Interesting is his mother, who gave him the gene, is not affected. She was screened and she did not have it. And this is again part of the different expression of SDH disease or SDHP disease, what we call sometimes intrafamilial heterogeneity. You can see her brother is affected and 2 of his sons are affected, but she carried the gene, she passed it to her children. She did not, she's now 70 years old and she did not develop a disease. This gentleman is in his 30 and she is in her late 20. And then this guy came recently with another manifestation. He came, this is an ultrasound of the thyroid and he has a mass there, and we did FNA and it turns out to be papillary thyroid cancer. We removed it. So that's another patient. Do I have 5 minutes, Amy, or should I stop here?
Can you hear me? I think you can have a few more minutes and then you'll be introducing.
Maybe 3 minutes. I hope to finish. Yeah. I just want to see them, to show them 3 more faces. So this is face number 4 of this lady. This is a man who is 56-year-old man. He had a long history with paragangliomas. He developed pheochromocytoma at age 20. At 32 years of age, he developed mediastinal chest paraganglioma. And then at 36 years of age, he had carotid body tumor. But the important message here, although he started to have paraganglioma at age 20, today he's 56. So he lived around 36 years and he's still alive and well, actually, absolutely well, with SDHB disease, and he's doing fine. This is his carotid body tumor. This is the first time I saw him. This is his mediastinal tumor that was there and has been there since he was 32 years of age, and today he's 56. So I think the message here, sometimes and many times, a disease like this can continue for many years and does not harm the patient. He has actually no symptoms. We could not remove it. It is behind the heart. This is the heart, major vessels here. So he is inoperable, but he is fine. He received extended radiation and remains stable. And this is his mutation. Again, one thing that he presented with is high hemoglobin. And you see, we had to do phenesection, bloodletting, to basically normalize his hemoglobin. His hemoglobin was as high as 20, which is quite high. And this is sometimes a manifestation of SDH and other mutations. Last one, this is a recent patient who came to me with with pituitary adenoma. No paraganglioma, no pheochromocytoma. And again, to cut the long story short, this patient had very aggressive pituitary tumor. We did whole exome sequencing. And for our surprise, she has SDHP mutation. And we confirmed that this is the reason for her pituitary tumor. So this is a rare manifestation of the disease. Fortunately, she responded to temolizumab, which is one of the chemotherapy. She did not respond to the conventional therapy, cabergoline or Dostinex, but she responded nicely. And you can see her prolactin went down. I will just show you the last patient because he's with us, our guest tonight. So Abdulaziz, who's going to be with us, he's actually with us now. He's a 28-year-old man, and no family history of paraganglioma or pheochromocytoma. He had varicocele, fissures around the testis in 2017. These are common, so they were surgically treated. But 2 years later, he had recurrence. So his physician did CT scan for the abdomen, and for his surprise and our surprise and the patient's surprise, he had 12 centimeter tumor that I will show you in a minute. He had no symptoms. He was fully healthy, athletic, exercising, and he's in the military. His urine metanephrine were normal 3 times and no symptoms. This is the mass. He has 12 centimeter mass in the left lower abdomen. This is the liver. This is the bowel. This is the PET scan showing the mass. This is the kidney, ureters. This is the mass. This is the bladder. But incidentally, he has another focus here. This focus turns to be in the thyroid. This is the thyroid gland. And you can see on the ultrasound, he has a mass there, or a nodule. We did FNA, and he also had papillary thyroid cancer. So Abdulaziz underwent surgical resection of the paraganglioma. You can see that you don't see it anymore. It was here, and now it's gone. And then he underwent thyroidectomy. The whole thyroid was removed for his papillary thyroid cancer. Unfortunately, his paraganglioma was quite aggressive. These features that I'm showing you here are signs of aggressiveness. And indeed, within a few months, he had spinal metastases and rib metastases. We gave him 6 doses of lutetium-177, and that seems to have halted the progression of the disease. And he also received extended radiation to the left 9th rib because he was having metastasis, painful metastasis there. And he is stable now with no progression for the last 14 months. And he has a very interesting collection of mutations that I will not burden you with. We went and screened his family. So this is Abdulaziz. This is his son who is carrying the mutation, but he's still 3 years old. His brother is a carrier, but he did not develop a disease yet, and his mother was positive. So I am going to stop here, and again, for the sake of time, introduce Abdulaziz, our patient who kindly agreed to join us. In fact, Abdulaziz is doing a lot of what I could say charity work. He participates, he encourages other patients, and he is really managing his disease absolutely well in terms of how he's perceiving it, how he's managing it. He basically enjoying his life fully without any concern, and thank God he's stable and he's doing great. So Abdulaziz, can you please show up on the screen. Abdulaziz may not be able to speak English, but I would be happy to interpret for him. Abdulaziz, ممكن تقدم نفسك الله يسلمك وتقول قصتك briefly. So he's going to say his story briefly, and then I will interpret what he says.
طبعا نبدأ يعني من البداية ولا؟
باختصار، قول أي من البداية بس باختصار.
باختصار هو كان عندي زي الدوالي على الخصية، وكان سببها الورم ضاغط على الشرايين. هذا اللي السبب الأساسي اللي خلاني أكتشف موضوع الورم. وبعد ذلك أخذوا خزعة وعرفوا طبيعة الورم، وبدأت بالتدريج العلاجي اللي هو تقفيل الشرايين، وبعد ذلك استئصال الورم، وبعد ذلك سويت اللي هو حقة الغدة، استئصال الغدة الدرقية بالغدد الليمفاوية، وبعد ذلك الورم اللي في العمود الفقري، واتجهت إلى ألمانيا لأخذ الليتيشيوم 177، والأمور إن شاء الله أنها مستقرة.
ممتاز Abdulaziz, شكرا جزيلا. So Abdulaziz basically repeated the story that he started with some fissures around the testis. When it came back, he did a CT scan, and that led to discovery of the tumor. He had embolization of the tumor followed by surgery. Then his thyroid tumor was discovered and was removed. Then he developed metastasis to the spine. He went to Germany. In fact, I had a number of Zoom meetings with his physicians in Germany. We agreed to proceed with lutetium-177 because at that time it was really progressing. But fortunately, after 6 cycles of lutetium-177, the PRRT, and external radiation to the left side of his chest, the disease stabilizes and he's doing great. طيب عبد العزيز حرجع لك، يمكن يكون في أسئلة، خليك معنا الله يسلمك. So Amy, with that, I will stop here and maybe we can take questions or discussion, and thank you so much for the opportunity.
Okay, that's great. And as a reminder, Dr. Alzahrani, stop sharing your screen so we can see you. So we do have some questions from patients. No, it's good. But I'm going to go ahead and jump right into the questions because we have a few. So the first question is, are there subtypes of SDHB? My sister had one around her carotid and has not had any more, but I have 5 tumors and none in my neck.
So the short answer is no, there are not subtypes of SDHB. It's only one type of SDHB. But as I mentioned in my lecture and showed, the expression of the disease is different. I showed you the lady and her brother having different expression of the disease. And the reason for this is not totally understood, but it is thought that there are additional genes that are not principally responsible, but they are modifying genes. So, and we don't know those genes. It's just a theory that there might be additional genes that modify the expression of the disease, but the disease is one. SDHB is one gene.
Okay, great. And I know you touched on this somewhat, but how common is it to have no relatives test positive, to just be the sole SDHB positive person in your immediate family?
Yes. So, if you have SDHB, you could be the only person, or everybody could have the disease. The disease is autosomal dominant, and autosomal dominant means everybody has 50% chance of inheriting the wrong gene and 50% chance of inheriting the right gene. So it could happen by chance that everybody is inheriting the right gene and you are the only person. And it could happen also by the chance that all of them will have the wrong gene and they will be carriers. So this is one part. The other part, the expression of the disease or penetrance is different. As we mentioned, the penetrance is not very high in SDHB. So you could carry the gene for the rest of your life and you don't develop paraganglioma pheochromocytoma. So this is the complexity with SDHB, but it is good that the penetrance is low. So you could have the gene and you don't manifest the disease. And again, you may you may be the only one in the family because you are the first person who developed the disease, or you could be the only one in the family because the other ones were lucky enough not to inherit the wrong gene or the wrong allele.
Okay. And so that we do actually have a question and on this, but it would be a good follow-up. So you said you can be the first person in your family with the mutation. So we would call that a de novo mutation, correct?
Correct, absolutely.
And
So you could be the first person. Yes.
is that common, or do we tend to see more people who it's a germline mutation that they've inherited from a parent? Or do you
So
see, is
there
it
is,
sort of mixed?
yes. So that's not very common. The more common scenario is that you have a family history. So people come and they have other people affected. Sometimes we don't know until, like Abdulaziz, for example, no, before we tested his family, they never know that they have a disease. And then when we tested his family, his brother, his son, his mother carried the gene. But de novo happens. There's a good study that I actually took out because of the time. And basically, a group from Germany and also US and Europe, they screened 271 patients who did not have family history. And out of those, around 60 turn out to have genetic mutation. Now, of those 60s, if I remember correctly, only 13 has SDHP. So those 13 are probably de novo. So de novo, which means the first person in the family, is not common, but it can happen. Most of the time, you
Okay.
inherit the gene from somebody else.
Interesting, though. It's very interesting. So we have another question. If you have the mutation, but no expression of the gene, all MRIs are clean, all blood work is good, and has been for more than 10 years, how important is it to continue surveillance?
I'm afraid to say it's important because this disease can manifest at any age. I think in one of the slides I showed you the penetrance at different ages. And as we get older, the chance to have a disease is more. So people in their 20s and their 20s, most likely they will not have a disease. For example, Abdelaziz's brother, who is now 18 years old, he doesn't have a disease. He is a carrier. He may develop it at age 30, 40, 50, 60, 70, 80, and he may even not develop it. So I think it's important. However, I think it is reasonable to decrease the frequency. You have seen the recommendation to do MRI every 2 to 3 years and biochemical testing every year. Although this is not the recommendation, but based on my experience, you could make it instead of, for example, every year, every 2 years. But this is, don't catch me on this. This is my own personal view. The recommendation is, as I showed you on the screen, is to continue to follow every year for clinical examination and biochemical testing, and every 2 to 3 years to do MRI or PET scan.
Okay, that's great. That makes sense, and that's good to know. But the most important thing is lifelong follow-up, no matter what, right?
That's correct. That's correct. That's correct.
So we have another question. We've seen renal cell carcinoma, glomus jugulare, and GIST in my SDHB family. Are there others to worry about? I think they're particularly asking about maybe other cancers beyond Pheo that might be associated with the gene.
Yeah. So again, I had some slides, but I skipped them. But let me mention one good news. The risk of other cancers or other tumors is extremely low. For example, the renal cell carcinoma, the chance is something like 2 to 5 in 10,000. It can happen, of course, but it is extremely low rate. The things that have been reported due to SDHP and other SDH mutations include GEST tumors. That's the gastric or gastrointestinal stromal tumors. These are usually benign. They can be malignant. And so this is one. They are still very rare, mostly in the stomach and usually multiple. And fortunately, they have indolent course. The second one is renal cell carcinoma, extremely rare that we don't generally worry about it. But of course, if you have it, you have to, I mean, it will come during the screening. If you do MRI, you will see it. If you do PET scan, you will see it. But it's very uncommon, very uncommon. And then the third one is the pituitary tumor, like the case I showed you a while ago. Other tumors are extremely rare and questionable whether they are associated or just coincidental. For example, Abdulaziz and the other patient had papillary thyroid cancer. But the data and the evidence on this is very questionable because papillary thyroid cancer is very common. So it may have happened just by chance. And we actually did some work in the lab to see if it is because of his THP, and we could not find evidence that it is. So the three tumors that you should keep in your mind, but they are extremely rare, is the GIST, the renal cell carcinoma, and sometimes pituitary adenoma. And most likely they will be discovered during the screening, during the workup, the MRI or the CT scan or the PET scans.
Okay. All right. Well, that's very, very helpful and informative. Thank you. I think we have time for a couple of brief ones. I want to get a couple more questions in if we can. So the next one is kind of a twofold question. I'm going to bundle a couple of. Is there a diet that's most appropriate for SDHB carriers with history of tumor or for those who don't have tumors? And then is diabetes common with SDHB?
So the short answer, no. Although the question is very logical because those enzymes, the SDH enzyme and other ones are in the mitochondria, which is, as I mentioned, the powerhouse of the cells. But to the best of my knowledge, there is no data to suggest that diet increases the risk of cancer or increase the risk of diabetes, or diabetes increase the risk of cancer. So, but we always encourage healthy diet and healthy lifestyle. It's known, for example, that obesity increases the risk of cancer in general, but not necessarily for SDHP or SDHD disease.
Great. Well, it's still good advice, and thank you for that. And then I think this may be the last question, depending on how long it takes to ask it. Have you found any information on whether in vitro fertilization hormones can trigger a recurrence of Pheo for SDHB positive patients with a history of large tumors?
I don't think so. I don't think there's data, but I don't think so too. I mean, from mechanistic point of view and from pathogenesis point of view, I don't think they affect the expression or the progression of those tumors.
Great. And then I'm going to ask you one more, and then I'm going to have to close. And I'm very sorry to everyone that's watching.
No.
Is imaging used to find the imaging that's used to find paragangliomas useful for finding other cancers that are related to this mutation? If not, what other scans should be used and when?
So MRI, yes, MRI can detect any tumor. It has no discrimination. So, but of course, it has also detection limits, especially in certain hidden places. PET scan, the gallium PET scan, is good for what is called neuroendocrine tumor, like paraganglioma, fuconocytoma. Sometimes they can be positive in renal cell carcinoma. Sometimes they can be positive in GIST. But the MRI is a very good test for all types of tumors, basically, except in the lung area. They don't detect in the lung because of the air. But in the mediastinum, in the abdomen, in the pelvis, in the head and neck, they are very good tests, and they will detect other tumors. Yes.
Okay, great. So again, I'm sorry to have to answer only a few questions, but grateful for your long presentation today and for the opportunity to meet Mr. Awaji. Please convey our sincere thanks to him for coming and speaking with us today. And of course, we'd like to give you our thanks for your dedication and time today. And again, to Mr. Awaji for sharing his story and perspective. I do want to remind our audience. I want to remind everyone watching that this webinar will be available in a few days. Actually, we'll try to be getting it out tomorrow on YouTube and on our website. We'll post notices on our social media channels. I also want to let everyone know that you can sign up for our e-news and follow us on social media to get updates about events like this, the party that we're having later today, and our monthly peer support meetings, among many other things. Finally, our year-end fundraising drive is underway. You aren't just our reason for existing, you are our most important partners in this fight against Pheo, and your financial support is vitally important to our continued success. Visit pheopera.org to donate online now. Again, special thanks to Lantheus Progenics for making this webinar possible. And finally, thank you to everyone who attended today. We'd like to wish you all happy holidays. I'm losing my voice, and the best in the coming new year. Bye.